So here to introduce our next presenters in our panel is Dr. Beatrice de Moranville. Dr. de Moranville is a board certified consultant in endocrinology, diabetes, metabolism, and works for a multi-hospital system of the South Coast Health Network, both in Mass and Rhode Island, where she has been director of their diabetes management program. In the area of diabetes, her interest is in lifestyle change, diet interventions, population health, and the application of insulin pumps and continuous glucose monitors in patients with diabetes. Thank you again, Dr. de Moranville, for being here, and I'm going to turn it over to you.
Thank you, Randy. So we're going to introduce now the team, the diabetes team. Our next presenters are here to show you a team approach to caring for diabetes. A care team is comprised of individuals with various areas of specialty. They complement each other with the skills, expertise, and experience that they bring to the team. The team approach is designed to improve communication, collaboration, and the higher quality of patient-centered care. The patient becomes the most important person on the team, enhancing satisfaction and improving health outcomes. Today's team is represented by Dr. Fadi Mansouradi, Nurse Sharon Campbell, pharmacist Dr. Jennifer Leavitt, and dietitian Anna Bertorelli. Dr. Mansouradi is a primary care provider at Fairlawn Primary Care in North Providence and is a member of Rhode Island Primary Care Physicians Corporation. Sharon Campbell is a nurse care manager at Rhode Island Primary Care Physicians and is certified in diabetes education and prediabetes. Jennifer Leavitt is a clinical pharmacist for Rhode Island Primary Care Physicians Corporation and Integra, working in multiple primary care offices. She has earned both the state and national certifications in diabetes education. Anna Bertorelli serves as Senior Health Systems Diabetes Educator for Novo Nordisk. She's a registered dietitian, certified diabetes care education specialist, and certified diabetes outpatient educator. I join our followers at home today in welcoming and thanking you all for being here today. Thank you.
Thank you, Dr. de Moranville. I'll start, and I have to say it's a little challenging and not fair to follow that delicious cooking demo, but we'll try, I guess. So I totally agree that diabetes management is a team approach. Is a team effort, and I think the team approach not only is beneficial, but it's actually essential to success a lot of times. We also feel that for that approach to be most successful, the patient has to be the lead person, the star of the team actually, and we feel like our role on the team would be more of a supporting cast than anything else. Diabetes is complex and can be challenging sometimes, and sometimes it can feel a little overwhelming. And I think a good diabetes team in place can help the patient navigate through that with less effort and more success. A couple of pointers. I think it's always important to remember that managing diabetes is a marathon rather than a sprint. The more one knows, the better one's equipped for success. And we always recommend setting goals. Unfortunately, we're not always successful, but all that should mean is let's learn from the first experience and be more successful the next time. Okay, so you skipped the title slide, which is good. I just wanted, in full disclosure and actually in team spirit, I wanted to make it clear that I had nothing to do with picking that title. So what is, next slide, what is diabetes? So a couple of definitions. One is, what is diabetes? Diabetes is basically when the body loses control of the blood sugar, and the blood sugar is constantly elevated. Glucose or blood sugar is the main fuel that the human cells utilize to generate energy. And it also happens to be the only fuel that brain cells can use. So for those who've experienced a hypoglycemic or low sugar reaction, you know what that feels like and why the brain feels like it's panicking in these situations. Another definition, so the insulin is a hormone that the pancreas makes, and it is at the core of diabetes. There are a couple of reasons or a combination of the two where diabetes can happen. One is the pancreas that produces insulin is not making enough of it. And that's what we typically see in type 1, whether it's from autoimmune mechanism or otherwise. The other cause of diabetes is there's plenty of insulin, but when what insulin does is it allows the blood sugar to move from the bloodstream or the supply line to inside the cells where it's needed for energy generation. So in type 2, what we see is the insulin goes to do its thing, but it encounters resistance at the tissue and cell level. So it's less effective. And that's insulin resistance is basically a typical feature of type 2 diabetes. So what the pancreas does in these situations is basically goes into work and tries to produce and put out more insulin to overcome that. But at some point, whatever the pancreas can put out is not going to be enough, and the sugar starts getting out of control, and that's when the sugar goes up in type 2 diabetes. And with time, you know, the pancreas from working too much burns out, and even that insulin becomes even less present less. A couple of core measures that we use to diagnose and manage diabetes. One is glucose. Glucose is basically that, and it's very easy and simple to check and widely popular and very accurate. The problem with checking the blood sugar is it gives us a snapshot in time of what the sugar is doing right now. But that's not to say that it's going to be the same in 15 minutes, an hour, or in a day. There is a lot of times people encounter wide fluctuations in blood sugar. So, and it's one situation that we often encounter is people often with diabetes check their blood sugars in the morning, and they see that their sugars are good. They don't bother to check it the rest of the day, and they feel that, oh, my diabetes is well controlled. And then when we do the A1C, it comes back a lot higher than expected. So just because a blood sugar is good one time doesn't mean it's good the rest of the day. So how do we get past that and get a better, a bird's eye view of the blood sugar? We use the A1C for that purpose. A1C basically is a way to kind of look back at what the blood sugar average was over the past 3 months. And now with the use of the CGM or continuous glucose monitoring, we have another way of looking at the blood sugar actually in real time and what it's doing. Next slide, Jeff, if you don't mind. So how do we define diabetes? The normal fasting blood sugar is under 100. And when it hits 126 or higher, now it's in diabetes range. As far as the A1C goes, normal A1C is under 5.7. And when it gets to 6.5 and above, that is in diabetes range. Notice that there is that gap in between where it's not diabetes, but it's not normal. And there's a reason for that. That's what we call either pre-diabetes, or if it's the fasting blood sugar that's not normal, that's impaired fasting glucose. And that gap area is very important because we can make a lot of difference if we find that. And next slide, please. So we all know what diabetes feels like, the symptoms of diabetes. But the problem with that is we usually don't feel that until the blood sugar level is quite elevated. 300s, 400s, etc. And there's all that space between 126 and 300s and 400s, where someone can have blood sugar in 150s, 180s, and feel perfectly normal or have minor symptoms and complaints that we can easily brush aside and attribute to something else. The problem with that is just because one feels fine, it doesn't mean that the diabetes is not doing damage to our organs. So if one simply relies on, well, if I get symptoms, I'll know it, I'll get diagnosed, we unfortunately are missing a few months to years of time where we can make an impact on preventing complications I will see in the next couple of slides. So that's why it's important to first, seek regular care, preventive care, and to figure out who is at higher risk for developing diabetes and try to screen them, on a regular interval situation. Next slide, please. So who develops diabetes? There's the genes, the genetic factors, and those are a factor in type 1, and probably a little more in type 2 as well. So people with family history, we recommend that they get screened on a regular basis. However, there are a bunch of other factors, and those are more of an issue for type 2 rather than type 1. One's age. So I guess with wisdom comes insulin resistance. So we always, at age 45, we start recommending regular blood sugar checks. Weight is another big factor. So the heavier we are, the higher the resistance to insulin. So people that have excess weight should also get tested before age 45. Certain ethnic groups, African Americans, Hispanic Americans, Native Americans, Asian Americans are at higher risk. So they should be a little more alert and be screened more, probably at earlier age as well. And some other features of insulin resistance would be a reason to screen. So someone that has high blood pressure, that could be a sign. Someone that, for example, has low HDL, that could be a sign. People with poor diet, sedentary lifestyle should be also counseled and potentially tested. Next slide, please. So as far as what organs does diabetes damage, I always like to reverse the question and say, what organs does diabetes not affect? Because most major organs are really affected by diabetes. And not to spend a lot of time on this, but so from strokes to heart attacks to vision loss from retinopathy to renal kidney failure to neuropathy and pain in the extremities to circulation problems to amputations, and I'm sure I'm missing a couple of major issues here. Why do these happen? I always use the analogy of a train that leaves the station and that's speeding towards these complications. The moment that one develops diabetes is the moment that the train leaves that station. And please notice that it's not when we diagnose diabetes that the damage starts happening, but when the diabetes happens. So the smaller that gap between happening and knowing about it, the better it is for us. And what determines the speed of that train towards complications is basically controlling the blood sugar and blood pressure and cholesterol, etc. So next slide, please. So what can I do to control my diabetes? To actually slow down the speed of that train and maybe stop it, bring it to a halt. So one, obviously, knowing my blood sugar, my A1C, working on controlling them and keeping them in the target range. But that's not the only thing. There are other factors that are as important, sometimes even more important than just controlling the blood sugar. So those include blood pressure, for example. Those include cholesterol. For blood pressure, just quickly, a lot of times if it's elevated, we like to use either a group of medications called ACE inhibitors or another group that's called ARBs or ARBs. Weight, exercise, nutrition, my colleagues will talk about that a little more. Cholesterol, we like to use a class called statins. Next slide, please. And I just quickly want to go through a checklist of things that we recommend on a regular basis. An eye examination on an annual basis, unless otherwise recommended by the eye doctor. A foot exam on a daily basis, and Sharon would recommend looking with a mirror to make sure I cover the entire foot. Seeing the dentist, having dental cleaning a couple times a year, getting a flu shot annually. Flu is probably more devastating for people with diabetes. The risk is higher. And the same with pneumonia. We recommend getting pneumonia shot once before age 65 and then catch a second dose at age 65. Aspirin is an individual decision based on the person's individual risk, and that's a discussion with the provider. We talked about statins and ACEs. Exercise will be covered later. Smoking obviously is, if someone has diabetes and they smoke, that's like adding fuel to the fire. It's very crucial that we get rid of the smoking habit. And last but not least, hopefully soon, next couple of months, we will be recommending also a COVID shot. And with that, I'd like to thank you and transition to Sharon.
Good afternoon, everybody. So how do we check our blood sugars? There's a bunch of different devices out there. A lot of them are very similar. They're daily check devices, just a regular glucometer, but different name brands. And then now they've come up with this continuous glucose monitoring, whereas Dr. Mansouradi mentioned earlier, the glucometer is just a moment in time, whereas the continuous glucose monitoring is a 24-hour picture. And that you can see in real time how food and drink are affecting you and in raising your blood sugars or lowering them. The CGMs, there are a couple out there. What we like about that is that they are usually a 2-week, 10-day to 2 weeks. And you can wear it in the back of your arm or in your abdomen, like whatever the device calls for and whatever you're comfortable with. Again, from a team approach, we really like the continuous glucose monitoring because the physician that's monitoring or your team that's monitoring has access, you upload the data and they have access to see how your body is responding in a 24-hour period. Which is very insightful. Like he had said, you take it in the morning, and if you don't take it the rest of the day, you're unaware of how your body is reacting. When and how should I check? Again, it's individual. It all depends on a lot of the times your medications. But a rule of thumb is first thing in the morning when you get up. Take it because that kind of starts your day, lets you know how you finished the day prior. And then we would also recommend before a meal and 2 hours post-meal. Jen, next slide, please. About blood sugars, like knowing if your blood sugar is high. Dr. Mansouradi alluded to these before, but it's a nice little cartoon, but it's, I think everybody's experienced this even when their blood sugars are low, not being diabetic, but these denote, what you could be going through. So to prevent this from happening, especially if you have diabetes, is eat at regular times. Don't skip any meals. Check your blood sugars pretty regularly. Take your medications regularly and try to take them around the same time every single day. And just recognizing when your blood sugars are low. If you start feeling any of these, we recommend, take your blood sugar. And, when we're working with the patients, we say, if you feel off, take your blood sugar. That way you can associate, oh, I felt sweaty and shaky and I took my blood sugar and it was 70. Then you have that correlation and you'll know better in the future. Jen, if we could go to the next one, please. So treating a blood sugar of 70 or below. And again, it's 70 is a rule of thumb. Diabetes is so individual. If your blood sugars and you tend to run high a lot of the times in the 200s, 300s or so, 70 might not be your low. You might feel those symptoms at 90. But again, it's great to have a plan with your physician for you, because it is so individual. But on a general rule of thumb basis, if it's 70 or below, eat, drink, simple sugars. We want to get that blood sugar up and up quickly. So there's some examples there. If it is below 70, we say eat that simple sugars. There's all kinds of, different things that you can do. Some examples are a half a cup of juice, a tablespoon of honey, 4 packets of sugar. anything, glucose tabs, skim milk, or whole milk, or any milk, you know, just to get that sugar up and get it up quickly. Check 15 minutes later. If it's still low, again, try another simple sugar, 15 grams probably. And that's why it's the 15-15 rule, to see if we can get it up. But the most important thing is, a lot of people don't realize, and they're happy once they relieve those symptoms, is once you get that blood sugar up, now these are simple sugars, your body's going to process them a lot quicker. So we want to maintain that blood sugar up. So that's where we need to eat a little bit more of a complex carbohydrate, where, like an example of cheese and crackers or half of a sandwich, just to get those blood sugars to stay elevated. Jen, if we could go to the next one, please. So, and again, here we have sick day management. Again, I'm going to reiterate, diabetes is individual. Even though a lot of people have it, it's to you. So it's really, really good to check with your physician that's managing your diabetes. If you have a care team, to have a plan in place. I can't emphasize it enough, especially going into the winter. You need to have a plan in place. So you want to be prepared. You want to keep your medicines and your supplies and foods in your house when you're sick. You want to check your blood sugars more frequently, because they do tend to rise when you are sick. You tend to sometimes eat less if you're having nausea, vomiting, diarrhea. So you really, really want to have that plan in place of what I should do when this happens. Another good rule of thumb is, when you're sick, to try to eat every 3 to 4 hours something, to get that sustenance in you and to maintain your blood sugars, because you really need, while your body's battling something else, you really need to have your metabolism up. Drink plenty of fluids for your, with it, and take your diabetes medicine. If you think you need to skip it, you need to call your physician. Like, you need to have a plan in place. And then another good rule of thumb is to have your sick day plan out or accessible if you live with other people, to make sure they know what it is. Because sometimes when our sugars are low, we get really foggy and like we can't, think about what we should be doing. So it's nice that if somebody else has your plan in place, that they can follow through on your behalf. Jen? And then exercise, physical activity, super important. Why is it important? Because you lose weight, you lower your A1C, you lower your cholesterol, you lower your risk of heart attack, you feel better, you sleep better, it lowers stress. I mean, exercise is the best medicine for any disease process, let alone, diabetes. And exercise doesn't mean you have to go out to the gym and purchase this equipment and all that. It can be that. But again, I would say check with your physician, your care team, on what you're capable of doing. But exercise could be just walking more than a stroll. And even if you can't walk, then stretch, like get that blood flowing. It is, such a vascular disease. So let's get that blood flowing. Let's get moving. There's all kinds of different exercises you can do in a chair yoga, and, do weights, just stretch, do anything. And you'll see differences if you exercise, definitely. And that's pretty much me. Thank you.
Good afternoon. Given our time constraints today, I won't be discussing any specific medications. As part of the Road to Wellness 2020 Challenge, there was a presentation given by Molly Seaschultz, which was dedicated solely to medications for diabetes. For those who are interested, we'll share a link in the chat for easy access to the presentation. Commonly, when I meet with patients, there's a lot they don't know about their medications, even if they've been taking them for a long time. So here are a few suggestions for what you should know. What is it for? Often people don't know why they're taking a medication, so they don't understand the importance of taking it. Know how to take your medication. And this includes several pieces. When? Is there a preferred time of day, or are there recommendations regarding timing relative to your food or other medications? How often should you take your medications? Is it something you should take on a schedule or only when you need it? Know the proper technique for taking your medication. Does it require preparation for a device, such as letting the product come to room temperature? Do you need to shake or mix the product first? How do you administer an injection with a pen or a syringe? Know how long you should be taking your medication. Is it indefinitely, a certain number of days, or only until you feel better? You should know what potential side effects to look out for, and if there are any special instructions for storing your medication or disposing of it. We know taking medication isn't always easy. We're busy. And sometimes we don't always remember, especially when we don't have a good routine in place or our routine changes. Maybe you're confused about how to take the medication. Maybe you didn't understand you needed to take it beyond that initial prescription. Maybe there was a language barrier or hearing loss that made it difficult for you to understand the instructions that were given. It can be difficult to take medication at work, especially if you don't have a consistent schedule. Mental health includes anything from depression and anxiety to schizophrenia and bipolar to dementia, all of which can make it very difficult for you to take medication regularly. I would also include diabetes distress here, which is when all the worry, frustration, anger, and burnout makes it difficult for you to take care of yourself and keep up with the daily demands of diabetes. It is okay to feel overwhelmed at times. Just let your care team know how you're feeling. We don't have them on with us today, but part of our care team for our patients is a social worker and a mental health professional. Side effects. Perhaps you took a medication and experienced side effects, so decided not to take it anymore. Maybe you're concerned about a medication because of what you read in the insert you received at the pharmacy, what you read online, what a family member or friend told you, a commercial on TV about a lawsuit, or medication recalls. All of these can skew your perception about the risks versus the benefits of the medication. Medication is expensive. Most people have health conditions in addition to diabetes, which require treatment, so costs add up. You may have taken a medication, but didn't notice any difference after you'd taken it, so you didn't bother to continue. Tougher still, some medications take weeks or months to see an effect, though side effects may be experienced right away. Maybe you don't want to take medication for religious reasons or cultural beliefs or values, or you may not want to take medication at all. I often hear people say, I just don't like taking pills. There are plenty of reasons why it's hard to take your medication, but it is important to take it correctly and to communicate any difficulty to your care team. If we don't know that you haven't been taking your diabetes medication, we may incorrectly assume that the dose needs to be increased, which puts you at risk for a low blood sugar. We could also incorrectly assume that the treatment failed, which could mean adding another class of medication and potentially more cost. It is important for your care team to understand your specific concern so they can tailor their approach to addressing them. So what can you do if you're having trouble remembering to take your medication? Build your medication into your routine. Try linking your medication to things you do every day. For example, when you get up or go to bed, when you're eating, or when you brush your teeth. Setting an alert to remind you on your phone or computer can also be effective. There are apps for your phone you can utilize. Pill boxes are very helpful in keeping medication organized. They can eliminate those moments when you're questioning whether or not you took your medication today. How many times have you wondered, was I just taking the cap off or putting it back on? Pill boxes come in a variety of sizes, and you can select one based on the frequency you need. Some have additional features like programmable alerts or allowing access to only one compartment at a time. Having your medications prepackaged is also a great option, and asking your pharmacist to help you set up a schedule that works for you and your medications. Medications can be expensive, and medications for diabetes are no exception. Whether you have a high deductible commercial plan or have Medicare and contend with the donut hole, you're not alone in having cost concerns. Please do not hesitate to let your care team know that your medication is not affordable. The medication certainly won't work if you don't take it, so we'll work with you to develop a regimen that's affordable for you. Utilizing generics whenever possible will help keep costs manageable. Insurance plans have preferred products, so using one of these products can help reduce your cost. Medicare Extra Help or RIPAY are assistance programs offered by the government, which reduce your prescription drug cost. There are income limits associated with these programs. A SHIP counselor at a local senior center can help you determine if you're eligible and also help you select a Medicare Part D plan. Manufacturers offer some assistance programs that you can apply for. These also have income limits associated with them. However, the limit is higher than that of the government-funded programs. New for 2021 is the Medicare Part D Senior Savings Program. This will limit the cost of insulin to $35 for a 30-day supply for those enrolled in a participating plan. The cost will remain consistent as the insulin will not be subject to a deductible or any coverage gap cost increases. Each plan can offer different types of insulin, so it's important that you review your plan choices to determine which plan would be best for you. If you take insulin and haven't already done so, review the available plans before open enrollment ends on December 7th. Manufacturer coupons may help with commercial insurance, but cannot be utilized with any programs that are subsidized by the government, like Medicare or Medicaid. You can also apply for grants, though these tend to fill up very quickly and have limited availability. Don't forget that any improvements you make from a lifestyle perspective, like increasing physical activity and making healthy food choices, always have value and may help minimize the amount of medication you need. There are a wide variety of products available over the counter, and they are convenient, easy, quick to access, and don't require an office or copay. Because an item is over the counter, many people assume it's completely safe, but there are some concerns to be aware of. Over-the-counter products can interact with other medications you're taking, and they may also have unintended side effects like raising blood pressure or blood sugar. Herbal products and dietary supplements are not regulated by the FDA. Just because the label says something's in the bottle doesn't mean that it is. Self-treating conditions over the counter and not discussing them with the care team could be problematic. You could be covering up a side effect of a medication by treating it with another, or potentially delaying more appropriate treatment. So always let your care team know what you're doing. So with that, I'll turn it over to Anna. Thank you.
Anna, you're on mute.
There we go. Good afternoon. And it's a pleasure to be part of this wonderful panel. Jen, could we have the first slide, please? So making healthy food choices, here's some general guidelines. The first is to put an emphasis on non-starchy vegetables. So rather than thinking about your protein or your meat when you're planning your meals, think about what vegetable am I going to have at this meal, and then plan the other foods around that. Choose whole foods over processed foods. For instance, instead of white rice, choose brown rice, or instead of juices, choose whole fruits. Choose fish 2 and even 3 times a week. Choose skinless poultry such as chicken and turkey over lean cuts of beef, pork, and lamb. Choose non-fat and low-fat dairy products such as milk or yogurt or cheese or fortified soy products. Minimize added sugars and refined grains. And then drink water, unsweetened tea, coffee, or calorie-free drinks or diet drinks instead of sweetened beverages. And when you cook, use oils such as canola oil or olive oil instead of solid fats such as lard or butter. Next slide, please. So when we look at the nutrients in our diet, there are 6 nutrients that make up our nutrients in our diet. So when we look at carbohydrates, there are 3 types of carbohydrates: starches, sugars, and fiber. And of those, we really want to place an emphasis on starches and fiber, starches sometimes being referred to as complex carbohydrates. And we want to have less sugars. When it comes to protein, proteins can be either animal or plant-based. They have varying amounts of fats. Whenever possible, keep the fat and protein on the low to medium side. When it comes to fats, choose healthy fats, such as monounsaturated fats and polyunsaturated fats, and less of the unhealthy fats, such as saturated and trans fats. Vitamins, minerals, and water make up the remainder of the nutrients in our diet. Next slide, please. So today we heard a lot about the plate method of meal planning, and you can refer to the government website, My Plate, or the ADA website, the Diabetes Plate Method. What we want to do is start with a smaller plate. So tonight, look at your plate. We want to start with a plate that's no more than a 9 or 10 inch in diameter. Take half of that plate as your non-starchy vegetables. And these can be things like green beans or carrots, mushrooms and spinach, broccoli, peppers, and onions. No more than a quarter of the plate should be your lean protein. The remaining quarter, your starches and grains. And then you can complement that plate with some low-fat dairy and a whole piece of fruit, and then maybe water or a low-calorie drink. Next slide, please. It's important to also look at the nutrition facts label. In 2018, the nutrition facts labels were revised, and a greater emphasis was put on serving size and calories because this is so important to people living with diabetes. So when we look at a label, let's look at that serving size and know what your portion that you're taking is. Then check the calories per serving. Look at the grams of carbohydrate and the grams of dietary fiber. And what's new now is that we can look at the added sugars. So when we look at the total carbohydrate, we want fewer of those carbohydrates coming from added sugars. You may also want to look at total fats and saturated fats, keeping these on the lower side. You may want to look at protein, sodium, and potassium, because sodium and potassium can help you manage your blood pressure. Next slide, please. So a great way to measure your portions is by using measuring cups and spoons. You don't have to use them every day, but periodically do that, because that way you can really know when you look at a portion what that cup is or what that teaspoon or tablespoon are. Another thing you can do is use your hand. So you could use, for instance, your fist as about a cup. So a cup of cereal or a cup of milk. The palm of your hand as being about 3 ounces, for instance, 3 ounces of boneless chicken. The length of your thumb is about a tablespoon, so like a tablespoon of peanut butter or salad dressing. The tip of the thumb is about a teaspoon of oil or butter. An open hand is about a slice of whole grain bread. And then the cupped hand is about a half of a cup. So you always have your hand with you. And then finally, I thought it was important to address some tips for holiday eating. So when it comes to holiday eating, try to stay on your schedule whenever possible. Avoid skipping meals because this may cause you to become over hungry and overeat later. Watch the amount of carbohydrates on your plate. Certainly enjoy all the carbohydrates, but take smaller portions. Choose fruits and vegetables served raw, grilled, roasted, steamed, but watch for those creams and gravies and butter that add lots of extra fats and calories. Stick to calorie-free drinks such as water, tea, seltzer, and other non-calorie drinks. If you drink alcohol, limit the amount of alcohol you have and make certain to have it with food. Be mindful of your eating. Take those smaller portions, but eat slowly. Really enjoy your food, savoring all those tastes and textures. And then after your meal, plan for a walk with friends and family, even if it's just around your home or neighborhood. And remember, if you do overindulge, don't beat yourself up. Come up with a plan to get back on track. I just want to thank you again for being a part of this panel and wish you all happy holidays. Thank you.
Great job to all the speakers. And now we're opening to questions from the audience. So I don't know if everybody saw my comments, but I wanted to say that when hypoglycemia occurs, when patients start to get symptoms of hypoglycemia, more than once probably is too much. I think it's a good idea to call your doctor for adjustment of the medications, because you don't want to, we call it to feed the medication. That's going to promote weight gain. And then you're going to be basically gaining weight and needing more medication. So we should do the opposite, reduce the doses rather than adding. What do you think, Dr. Mansouradi?
Yeah, absolutely, Dr. Mansouradi. I completely agree. Plus the other risks that come with hypoglycemia, and we know that it probably raises the risk for heart attacks, etc. So I always think of hypoglycemia as something to avoid. And if it happens, you take a look at why it happened, whether it's medications, time of the day, skipping meals, and how can I prevent the next one from happening? Absolutely.
Right. There is a question in our chat. Does metformin work okay when patient has IBM as well? Dr. Mansouradi or Jen?
Jen, leave that for you.
And what is IBM?
IBM is
irritable bowel movement.
Irritable bowel, okay.
I assume it's
Irritable bowel disease.
Yeah.
So my quick comment is it works, but.
It works, but is it tolerable for people? And so metformin, one of the common side effects is diarrhea or stomach upset. And so certainly we would need to make sure that you weren't having that before we continued with a medication like that. So it's going to be person to person, but medication, metformin is one of the best medications we can start with, so.
And I posted on metformin because I've heard a lot from my patients. They hear or read stuff on metformin. And there was a recall on some of the metformin product, but it's not really the medication. It is safe and effective.
Yes, metformin actually can cause diarrhea. So patients with known irritable bowel syndrome can still try it. But if patients experience diarrhea after they started metformin and it seems to be affecting their health, that probably would be a medication to stop, because sometimes that's the only, that is the cause of the diarrhea. So then you would have to change the treatment. Let me see, any other questions? Okay.
So I guess if no other questions are coming, we do have a couple of myths that are on the slide, and maybe you can take a quick look at them. So eating too much sugar causes diabetes. So not directly, but through causing weight gain, of course, it can. And if we already have diabetes, sugar can spike the blood sugar rather quickly. You catch diabetes from someone else. My answer to that is, of course, from your parents, but otherwise probably not. Only overweight people get diabetes? Absolutely not. And there's a question, I think. So when you are diabetic for 6 years, then in 1 month I was out of range with high number, huge blood pressure. I was under care of my primary cardiologist. Sugar is down with low. Okay, so, you know, as far as, is it bad to have blood pressure and diabetes out of control for a month? So the longer, the worse. And the sooner you get things under control, of course, the better it is. And any other comments? And again, blood pressure is very important, especially if someone has had diabetes for 20, 30 years. It almost supersedes controlling the blood sugar, I think.
Yes, you would need to treat your blood pressure with the medications that were mentioned by Dr. Mansouradi, probably an ACE or an ARB. So yes, go back to your doctor for management of your blood pressure.
I like this last point. What about COVID-19? Can the panelists talk a little bit about that?
So I'll go first. So COVID-19, obviously, especially in the midst of this spike that we're experiencing, so people with diabetes are not more likely to get COVID-19, but they're more that are higher risk for having more complications, for getting sicker, for ending up in the hospital. And it turns out that it for some reason affects blood sugar control. People with COVID-19, especially in the hospital, have had quite a bit of elevated blood sugars. For some reason, transient insulin resistance. Some people have had a DKA, a diabetic ketoacidosis, and coma, and the risk of complications is higher. So we want to protect ourselves if we have diabetes even more. And also because of these fluctuations, one would want to have a sick day plan. Hopefully, if we get COVID, it won't be bad enough to end up in the hospital. The other thing is whether it's, I've heard from people that it's only type 2. Well, we know more about type 2, but it probably is the diabetes. It may be a bigger deal with type 2, but even people with type 1 are at higher risk. Any comments from the rest of the panel?
I'd like to add, I think it's really important to, be prepared for any illness during this time. Make certain that you have your diabetes supplies and extra diabetes supplies, and then have a sick day plan in place, including telephone numbers of your healthcare team and any foods or beverages that you may need or any medicines that you may need should you get sick. And certainly, take this time to get into as good diabetes control as possible. If you have those visits with your healthcare providers, to meet with them, whether they're in person or telephonically. So, thank you.
So there is a question. Terry is asking, I have diabetes, dawn phenomenon, and take a little bit of insulin for it at night. If I don't eat anything after dinner, my sugar is high in the morning. If I want a snack at night, what are good suggestions? And is this something that I might have forever? Dr. Mansouradi?
Oh, I'm sorry. I thought I'll have Anna tackle the snack part. So I think as far as snacks, the one thing I would caution against is a snack that's basically sugar, because that's not going to last too much. So if we're planning overnight, you want something that has a little bit of protein and maybe a little bit of fat. So whether it includes a little bit of sugar, cheese, maybe peanut butter, or any other ideas for snacks. Now, is this a lot of people, and I'll probably defer some of that to Dr. de Maranville as well. A lot of people do experience the dawn phenomenon. Sometimes it's a little hard to manage, but I think if you've found that you can control it somewhat with having a snack at night, that's wonderful.
And then perhaps do some extra blood sugar checks. There may be a need for medication adjustment. That might be another thing to think about. And then, looking at things like your diet and physical activity during the day and how that might be impacting your blood sugars.
And also infrequently, the dawn phenomenon could be something else, actually. Occasionally, if you have a significant low sugar during the night, early morning, by the time you wake up, the sugar may have rebounded. It tends to over-rebound. So it's important to make sure that this is not a reflection of low sugar during the night.
Correct.
I think Randy wanted to add something.
No, Dr. DiMaranville, but there is another question in the chat I noticed.
Oh, okay. What are your thoughts about Ensure or low sugar protein bars?
Would you like me to address that?
Yes, that would be
sure. So I think they're fine as long as you achieve the blood sugar control that you are seeking. Sometimes these meal replacements are helpful if you're going to be skipping a meal or just can't have a meal. I'm thinking of, for instance, some of our very busy healthcare workers, sometimes they don't get to have a meal. So, but I do think that you'll want to check your blood sugars and make certain that you're achieving the control you're seeking. And did anyone else want to comment or have a thought?
I think that's actually important. The scenario where checking your blood sugars after eating or after taking that snack, or in this case the Ensure is going to play a role to see if it is helpful or not, because some of those supplements are protein supplements, which are probably good, but some of them probably contain too much sugar. And to comment a little bit on the previous question by Terry about hypoglycemia, or I'm sorry, the dawn phenomenon, what Dr. Mansouradi said is very important, because yes, indeed, there could be hypoglycemia, and then the dawn phenomenon actually has a different name, would be called Somogy event, in where there is a rebound and there could be a high sugar on awakening because of a low sugar that happened at night. So the first few times that you take the insulin, check the blood sugar at 1, 2 o'clock in the morning to make sure it's not too low. Especially if you're taking insulin, probably NPH has a little peak, probably 6 to 8 hours after you take the injection, 6 hours after you take the injection. So make sure you're not having a low glucose at that time.
And that's one of the nice things about having a CGM, which as long as you scan, if it's the Libre, it tells you what's happening during the night in 24 hours. So you know if it's high, if it's low, and what meals trigger it.
Right. All right, so Randy also made a point here, a great point about healthcare workers who might also have diabetes and working long hours right now. Okay, so that was related to COVID. All right, any other questions or concerns? Let's see, it's 2:57. So I think that this is the time that we have to wrap up, right, Randy?
Yes, I want to thank all of our panelists again for your time and really for showing all of us the importance of team-based care as well in helping individuals to manage their diabetes